need to be regularly screened for liver cancer, which is as simple as an ultrasound a year. And what we found, our survey of doctors in UCSF as well as Stanford, is many doctors did not know about the high prevalence of chronic hepatitis B in the Asian population. And actually, the chance of an Asian population of chronic hepatitis B is about 1 in 12. For a white person, is 1 in 1,000. Okay. Many of them did not know how to screen and did not routinely screen their patients. And many of them did not know how to care for these people, patients with chronic hepatitis B. And at that time, there was no national initiatives to raise awareness or promote screening, and there was no comprehensive national strategy to prevent monitoring and treatment. So what this actually, our research showed, this actually represents the biggest health disparity in this country. The prevalence of chronic hepatitis B and liver cancer in Asians versus non-Asians. So with the support of the dean at that time, Dean Jean Bauer, and the CEO of the hospital, and with a single donation at that time of $50,000 from one donor, we raised the flag and launched the Asian Liver Center. And we really sort of sent to focus on addressing gaps. The gaps in hepatitis B and liver cancer awareness, research, and national policies, both in the US and in other countries in Asia. So through an acronym, we say CARE, which stands for Building Partnership and Collaboration, Evidence-Based Advocacy to Affect Policy Change, Research, Education, and Training. We have a very ambitious goal towards global elimination of hepatitis B and reduce the burden of liver cancer worldwide. So I noticed, interestingly, your center is, the acronym is also CARE.
Standing on the shoulders of giants.
So over in the last 22 years, we have to overcome many challenges like raising funds, space, and all that. But the results has been very gratifying. Based on our research and advocacy, now for every Asian American, for a hepatitis B screening test is now covered by Medicare and Medicaid. So there's no excuse for doctors not to order them. It's available, it's recommended for all Asians, as well as non-Asians who came from endemic countries, which is pretty much everyone except if you were born in Western Europe and North America. Okay. And also, we have now actually helped to establish a global strategy, and we are helping countries in Asia, including China, Vietnam, Mongolia, to meet the targets of a 2030 viral hepatitis elimination goal, which all the countries in the world have signed on. So because of the limited time, I can't really share with you all the research we've been doing for the last 20 odd years, but I hope you will just check out our website at liver.stanford.edu, or I actually brought some of our little pamphlets, and you can welcome to pick up one of them. I'll leave it out there. So when on your way out, you can pick one up and see what we have been up to. Thank you very much.
Dr. So is actually too humble. I recall that you told us you actually gave part of your salary at the beginning to support a nurse for this effort. So
in those days, you'd be so surprised. In those days, there were very few Asian nurses. Okay. So I think I started a multidisciplinary liver cancer program at the Cancer Center. And in order to provide culturally, linguistically appropriate care, I actually contributed 1/3 of the nurse salary to hire a Vietnamese-speaking nurse. And she was the first nurse in the Cancer Center who can speak an Asian language. Wow.
Thank you for inviting me to speak about the Journal of Asian Health. So the purpose of this was that we had in mind was to increase the knowledge of health of Asians around the world. I went to China in 2010 and 2011 and went every year after that, and I realized that there were certain health disparities, and it was very interesting that diabetes, for example, metabolic syndrome was just taking big at that time in America. And at Stanford, you have Dr. Gerald Reaver, who really created the Syndrome X in the year 2000, so it's like coming home here. And we wanted that, we thought that a journal would be a useful and practical way to share knowledge and bring together diverse groups of people around a common goal of really thinking about health in Asians and the Asian diaspora. I'm Chinese Cuban, so I belong to kind of two diasporas. So here is our journal. This is our homepage. We have an ISBN number up top. It took us like a year to get it, wade through the federal guidelines and all this. And we have various ways to deal with abstracts, news reports, authors, and there was an article about health status of multi-ethnic women in Taiwan, and very interesting about the sub-ethnic groups within Taiwan. And we have a blog. We found that there's increased occult atrial fibrillation and cryptogenic strokes in Asian patients. This is a Japanese study, and there are genes associated with atrial fibrillation in the Japanese population, and Vietnamese female with hepatitis C carrier and came in with herpes uveitis that was very severe. So this is our journal. There's Korean bloggers and Japanese bloggers. And we have a YouTube video link. And you can scroll and will be in many different languages. And we have abstracts, like for example, Chinese glaucoma is different from Japanese glaucoma, different from Caucasian glaucoma, different from Russian glaucoma. So the corneas are different in diabetics and Asians versus Caucasian corneas. So thank you very much for having me. This is a great, center, and I, so happy that it exists in the Bay Area.
I think I forgot to mention, please try to speak into the microphone because we're trying to record it, but we got to mention that. Dr. Allison Kurian, who explains genetics better than anyone I've ever met. So.
Well, you're far too kind, and that's quite a lot to live up to. Many thanks for letting me be here tonight to talk about some of our work with breast cancer genetics in Asians. So as an introduction, we know that breast cancer is different in U.S. Asians. The first figure is by our wonderful colleague Scarlett Lynn Gomez, who's worked with many of us using registry data to understand cancer and other risks. And what we can see here is that in recent years in the United States, we see that breast cancer is rising in most Asian subgroups, whereas we really don't see that in non-Hispanic whites. So there are clearly differences there. Scarlett Gomez and I and other colleagues have done work using registry data to understand different biologic subtypes among Asians. And here, unfortunately, we did lump Asians together and clearly need to tease that out more. But when we look at breast cancer as a whole in green, all types of breast cancer, you can see the differences, highest rates in whites, but Asians are right up there. When we look at different subtypes, the red or hormone positive are kind of the good subtype, the blue or triple negative are the bad subtype. You can see the distribution is different. Asians seem to have less of that bad subtype for reasons we don't really understand. But I think it's clear that there are differences and really important questions about what drives them. We've done some work in the Women's Clinical Cancer Genetics program looking at differences in breast cancer genetics in Asians versus Caucasians primarily, but other groups as well. And we do a lot of genetic testing here. And we use models to estimate the likelihood that a patient will carry a BRCA1 or other gene mutation based on family history. One thing that we saw a few years ago that was pretty interesting was that models that work well in whites, and this is a curve that measures that, actually don't work so well in Asians. And that's kind of interesting. So is that because with the same genetics, Asian patients are less likely to get a breast cancer, maybe due to differences in environmental factors, reproductive factors, or gene by environment interactions? That's been interesting. And we've learned that because of this, Asian American patients less often get indicated genetic testing, and so their risks of breast cancer go undetected. That leads to another problem that we've recently published about, which is that because patients are under-tested for cancer risk, we know less about the genetics of breast cancer in Asians, and that's another problem. So I know Latha and others are familiar with this. When we go sequencing genes, we sometimes find variants of uncertain significance, subtle changes that probably don't make trouble clinically, but we're not sure. And they tend to be more common in particular genes and ethnic groups that have not been well characterized. And we know it's also a problem because these variants may be mismanaged by clinicians, causing unnecessary surgery. So in recent work, we found that while Asians have the same roughly rate of the yellow pathogenic or harmful mutations as other racial ethnic groups, they have more of these pesky variants of uncertain significance, certainly than whites, but also than others. And the figure on the right just shows that this gets worse with the more genes that you test. So here, a testing access disparity for many reasons really perpetuates information and treatment disparities in care. That's just one example of what we see. So to close with future directions, we are really interested in population-based genetic testing data. We've been fortunate to get R01 funding for a large population-based study in California, so 39 million people in the state, many different Asian subgroups, linking to genetic testing data. I think we'll learn a lot. We're also working on interventions to improve access to genetic testing, both in terms of education and other strategies. And I think key priorities are really to characterize genetic differences in cancer risk, as well as targeted prevention and treatment approaches. Many thanks.
Thank you, Allison. Next up, and last but not least, Dr. Fumi Kino, who wears many hats, among which is Director of Japan Biodesign, as well as researcher in cardiology, as well as venture capitalist.
Yeah, thank you very much, Brian and Latha. And okay, my name is Fumiaki Keno. I'm originally from Japan 18 years ago at Stanford. Still, I'm here. At that time, I could not speak any English, but now I'm speaking English. I'm very surprised. but my father passed away 10 years ago because of stomach cancer, Zygote ring cell carcinoma. So I'm a high-risk patient of stomach cancer. So why I motivated this project? Because just only for myself. And for my kids, they grew up in US, but they're totally Japanese American. So that's the main motivation for me. But anyway, so Japan is a small, very small, isolated island, and it takes about 10 hours. It's not so far. So, and also, there are lots of big difference. So, for example, aging rate is 28% compared with the United States, 15%. BMI 22, you are 28. You means not everybody. You know. And obesity rate is 3.6%, and the US is 36%. So totally different. So we should think about, most of the